Monday night here, aired out. This is a show that if you suffer from any kind of addiction or if you know someone that is, please get them to watch, send them the link, comment, share, subscribe. We would love to hear from you. I am honored to have with me a licensed psychologist and a licensed alcohol drug counselor with me in the studio tonight. On this Monday evening, this is Dr. Rick Barnett. Welcome.
JD, happy to be here.
I'm so happy to have you here, man. I just met you a couple of weeks ago, and we've been in touch, and here we are together, sitting down on Aired Out. We were chatting about addiction, and I got a little funny with you and said, yeah, I'm addicted to food, but that's actually really not so funny. And you later told me that that's probably the most common addiction that you deal with is people who love to eat and can't stop eating.
Yeah.
Stress eating. That's the most common thing.
It's common, what's also common, interestingly enough, is that people still debate whether or not food is actually an addiction. Because food is so necessary for survival.
Sure.
So why would we want to label something that's so necessary for survival as some sort of addiction?
Yeah.
And yet we know, at least as a phenomena, from your own experience, my own experience with sugar, with certain types of comfort foods, there's something going on there that really closely mimics an addictive process. If we can't agree that it's a full-blown addiction, we have to agree on something. And I think what I said to you when you mentioned that is that of all the addictions that I treat, I would say food addiction, if you want to frame it that way, is one of the most difficult, if not the most difficult addiction to treat because of that profound biological aspect of it. We need food to survive.
Sure.
So then what do you do?
Sure.
And there are all kinds of restrictions and diets and lifestyle changes and all these things, but it's really tricky, especially when it comes down to one's psychology, how one thinks about one's relationship to food and the gymnastics that go on. I mean, the most incredible things that people use in their minds to justify why, they need to keep eating or why they can't stop themselves. It's really fascinating.
The firing and wiring of the neurons, whatever they are, up in your noggin, that are calling for that food. And I know, I'll tell you, honestly, I don't think I'm being funny here. I think I am addicted to food. If I don't get enough food during the day, I feel sluggish, I feel run down, I'll get a headache. And by the end if I eat well during the day, breakfast and lunch, by nighttime, by 7 or 8 o'clock at night, wicked carb cravings.
Yeah.
And sugar cravings, especially after 8 o'clock at night. I've got to have the chocolate and I've got to have the peanut butter. And those are my two biggest weaknesses right there. I crave peanut butter and chocolate every night.
Yeah.
And it's one of those things that I cannot say no to it. I mean, I can, but I struggle to say no to those things. Yeah. Do you ever get wackos like me saying stuff like this to you?
Oh yeah, for sure. Like I said, it's like one of the most difficult things to overcome. And when people come to my office, not a lot of people have come to my office over the years to specifically say, I believe I have a food addiction. Can you help? Typically, people might go to a nutritionist, a dietitian, their primary care physician, not necessarily a psychologist. They'll come maybe with food issues or weight issues or something along those lines and want to talk about depression or anxiety or traumas, all of which are very real and very worth, just trying to process. But you can't do so if there is an addictive, you can't just focus on the depression or the anxiety or the trauma if there's also an addictive process going on.
Sure. That's so interesting. U.S. News and World Report we're going to talk about drugs here. Drug addiction, I'm sure, is one of the big things that you deal with. They just came out with a new study, and I want to read this to you. It says more than 2/3 of teenagers and young adults who overdosed on opioids and survived did not receive timely, evidence-based addiction treatment. Wow.
Yeah.
That's alarming right there.
Now, tell me from your perspective, when you hear a statistic like that, what makes it so alarming?
I think that folks are not tapping into the resources that are available to them, or they're just simply not aware of what's out there. Especially if you're overdosing on something and you're able to survive. It's a tragedy if you are not then directed to someone like yourself.
Right. Well, so the thing is, I think I would want to go see where the study actually came from. U.S. News and World Report is presenting this data. It's based on a study probably published in a peer-reviewed, reputable journal.
It's the Truven IBM Watson Health Market Scan that researchers did across the U.S. from 2009 to 2015 is when they did this study with these claims here.
So a couple of things, though, JD. What they're saying is when they didn't receive timely access to evidence-based care or proven treatment care, what they're talking about, if I were to just be blatant about it, what they're talking about is medication. What they're talking about in studies like this, when you hear statistics like that, is that these youths who overdosed on opioids and survived, they're saying that 2/3 of them did not get access to medication like buprenorphine or Suboxone, methadone, or naltrexone or Vivitrol. Those are 3 approved drugs to treat opioid use disorder. So when you hear statistics like this, they're saying that 2/3 of these young people did not have access to those life-saving medications. The problem with that is that what percentage of those 2/3 that survived an overdose did not want treatment for their condition? What percentage of them refused treatment? What percentage of them had access to it and for whatever reason chose not to get the care? And for what reasons did they choose not to get the care? Was it the distance to the location of the clinic?
Right.
Was it an insurance issue? Was it they knew somebody that worked there or the place has a bad reputation?
Yep.
There's all kinds of things that go into the sort of the backstory. And those of you who know me, who may be watching, if you follow me on Twitter at Dr. Rick Barnett, it's DRRICKBARNATT, my name, at Dr. Rick Barnett. I'm very active on Twitter, and I try to be very balanced in my perspective about pharmacotherapy. That's what I call it. A lot of times it's called medication-assisted treatment. That's the buzzword that everybody uses, medication-assisted treatment. That's supposed to refer to not just pharmacotherapy, not just buprenorphine or Suboxone or methadone. It's supposed to be medication plus counseling.
Yeah.
And
combination.
And there's a lot of debate out there. In some cases, counseling really is it's an extra barrier for people to actually get the medication they need. In some cases, medication is just is misused or not as effective as people like to think. One of the statistics related to that, and you can tell I can go off on this subject very easily, and that is that, believe it or not, those medications that they're referring to that youth aren't getting access to, this means, what I mean by youth is like ages 16 to 25 approximately.
Yeah, they have 13 to 22.
Okay, 13 to 22.
On this
they have
study.
the highest rates of dropout of the treatment that you're talking about. Of all people who actually get into a treatment program that offers these medications and maybe some counseling, there is a very high dropout rate for young people.
Yeah.
So these people in this study, I would want to know, had they accessed treatment before and they dropped out and then they overdosed and then they didn't want to go back again because they already tried that and it didn't work for them. there's a lot of different things that go into statistics like that. I do believe, just let me say it on record, I do believe that young people, people of any age, must have access to these types of medications. They must. But just having access to them doesn't mean they're working for everybody. And Vermont is, if you look at some of the rates of access to healthcare in Vermont, versus the prevalence of addiction, alcoholism, the amount of suicides we have, the mental health issues, we have incredible access to healthcare, and we have very high rates of all those things.
Right.
So just because you have access doesn't
Yes.
mean, you know, people are getting well.
Yeah. That's the biggest, that's probably the biggest concern, I think, that folks in your profession probably have, is that disconnect
Yeah.
right there.
And we have a fantastic healthcare system. I've worked hard with state government officials, with different groups to try to redesign the healthcare system here in Vermont, and it's a very, very complicated process. In fact, I just served on the Rural Health Services Task Force Committee, presented a report to the legislature this last week, and we had some pretty concrete recommendations in there. But just because we have really, really good access to care in many domains in Vermont, with the exception of mental health, I would say, that we still have a very challenging population to deal with a lot of health issues.
Yeah, for sure. This particular study, is just glancing here, this says that the 2/3 did not get behavioral health services for whatever reason, including all of those drugs that you just listed, for both behavioral health services and pharmacotherapy. Am I saying that right?
Yep.
Within 30 days of the incident overdose.
Mm-hmm.
Then it goes on, it says they found that 3,606 youths who survived an opioid overdose and remained enrolled in Medicaid in the 7-year period, 2,483, that's just under 70%, did not receive addiction treatment within 30 days of the overdose. And just over 1,000, just about 29%, received behavioral health services alone. And only 1 in 54, that's just about 2%, received medication-assisted treatment.
Mm-hmm.
Yeah.
Yeah, that's significant. That is significant. So I would say, again, I think a lot of people who follow this kind of research and work on the front lines of addiction, a lot of people say that we have terrible access to
Yep.
these life-saving medications. And I would say that, that is both a major issue, that people need to have access to these medications,
Yeah.
but I would also say that we've targeted opioids, both in terms of prescription painkillers and in terms of the antidote or the treatment medication, Suboxone, methadone. We've targeted opioids as both the savior and the villain in this drug death epidemic. And I don't think we're going to force people off their prescription opioids to save lives. And I don't think we're going to, supply the entire United States with Suboxone or methadone and save all these people. It's much more nuanced and much more complicated than that. But we target opioids, and people aren't overdosing just on opioids alone.
Right.
We're talking about multiple drugs in their system. When you look at mortality data, you look at the coroner report, the medical examiner report, what they find in people's system is not just opioids. A certain percent is opioids alone, and opioids absolutely contribute to probably 2/3 of the drug overdose deaths, but not opioids alone.
Interesting. I should just add here that these stats that I just came out with a minute ago were published Monday in the journal JAMA Pediatrics. I'm guessing you're familiar with that. You're nodding your head.
Yes, the Journal of the American Medical Association, the pediatrics department, the division of that.
I just had a podcast a little while ago with a couple of police officers in here that we were talking about driving sober and driving under the influence, DUI, DWI. They had a lot to say. I don't know if you got a chance to see that show, but one of the things that they said of the non-alcohol drugs in the system, the number one drug that these DREs are finding, drug recognition expert in the police force, is marijuana for the state of Vermont.
Mm-hmm.
Are you surprised by that?
Not at all. Not at all. It's fascinating. You should bring that up, and I definitely want to watch that episode because I don't know if the listeners are aware of this, but my nonprofit organization, Carter, that's at cartervermont.org.
Yes.
Carter Inc. stands for the Center for Addiction Recognition, Treatment, Education, and Recovery. That's cartervermont.org or addictionvt.com. We actually run we're contracted with the state of Vermont to run the impaired driver rehab program in Franklin County, Addison County, and Lamoille County.
Yes.
And I teach the class. It's a 10-hour class. If you get a DUI, first offender, second offender, you have to take the class. It used to be called Crash. Used to be called Crash. Now it's called IDRP, Impaired Driver Rehab Program.
Okay.
And I run that in those 3 counties. And I find it fascinating hearing people's stories. Of course, I've worked as a counselor for a long time, so I've done the mandatory counseling that people have to do when they get a DUI. So I've heard all the stories. You know, I'm not surprised at all by the cannabis, the DREs picking up on marijuana. You know, it's still a subject of great debate. The material that we teach as part of this program is very clear about drugged driving.
Yeah.
We talk a lot about alcohol during this 10-hour course and about what's healthy, what are low-risk choices and high-risk choices around alcohol. But it's very clear, no amount of cannabis and driving is the only low-risk choice. And it's problematic because the pharmacology of cannabis is very different than alcohol.
Right.
The way in which people function under the influence of cannabis over time varies dramatically compared to alcohol. And also the concept of tolerance. If you think about tolerance for cannabis, now, sure, there's some people we know smoke a ton of weed. They do dabs, they have the gummies, the edibles, whatever. They're used to lots of THC flowing through their system, and they just go about their lives every day. They're driving, they're working, they're doing their thing. They're stoned, they're high. Their THC levels are high in their system all the time. But they've developed such a tolerance that it's just who they are. Now, people can do that with alcohol too. There are people walking around with a blood alcohol content of 0.2, 0.3, whatever it is, and it's a miracle that they're standing and functioning. But their motor skills are impaired. Their reflexes, their executive functioning, planning, organizing, it's really impaired.
Rationalizing.
They can rationalizing. They can still function. But it's very different with cannabis, and there's big debates about that. About like, well, can somebody really drive high? And they've done plenty of studies on it. They show.
Yeah. They show what?
They show that people who drive stoned tend to drive slower. They tend to get distracted very easily. They don't veer over the yellow line. They sort of wobble in between the white and yellow lines. They don't actually cross into the other lanes nearly as much as people who are intoxicated on alcohol. But they still show some types of very clear impairment, which is like reaction time, distractibility. You know, if you're stoned and you're driving, you're changing. You know, if you look at your phone, God forbid, or start texting while you're stoned, it's harder for you to sort of adjust your attention from your phone or from the radio or from talking to somebody or whatever back to the road. So you get distracted very easily. You're drunk, you're driving erratically, you're not really paying attention, your motor skills are way out of whack. It's much more dangerous, I think, to drive. And then think about the combination, JD.
Yeah, the combination.
The combination.
Of course,
and they're seeing that in Colorado, you know?
So you think it's much more dangerous to drive impaired by alcohol?
Oh yeah.
Okay.
Yeah. And I'm not saying by any means that it's not dangerous to drive under the influence of cannabis. If you smoke a big joint and you get behind the wheel and you're stoned out of your mind, it's really dangerous to
And
drive.
and for some folks, it doesn't have to be a huge joint. It could be one hit.
It could be one hit. I mean, you've got dabs, you've got shatter, you've got these forms of THCs, high potency.
Yeah.
You can just do a little bit, and you
Right.
can be really, really stoned for an hour or two. And you definitely should not be driving for a few hours. You shouldn't be driving at all the whole day. But people do. They might smoke in the morning and
Sure.
then drive later on the day.
We both know, because we both have seen it all over social media when Vermont first legalized. Almost immediately, people were getting on social media saying, oh boy, what now? What about, impaired driving? And there were a good number of comments that I read on Facebook of, it's absolutely fine. It just relaxes me. That's all.
Mhm.
I don't drive any differently, whether I'm stoned or not stoned. Boy, I tell you, there's some division on that subject.
Oh yeah, well I'm sure there. Like I said, I'm not defending. Don't think it's a good idea to drive stoned, but
Right.
there are people who are just used to being high all the time. They
Yes.
drive, they function, they do everything stoned, and there are people who are just not used to cannabis. People who may be more tired than usual, more sensitive to it for whatever reason. They don't have a high tolerance. They're not used to smoking high potency weed or using these
Sure.
edible products, and it totally throws them out of whack. And they definitely shouldn't. They're not good drivers. But the people like you're mentioning who commented on Facebook, the fact is that Vermont has some of the highest rates of cannabis use in the country, especially for young people, double the national average, I think, and like for
Yeah.
12th graders.
Yeah.
And they're driving all the time. It didn't change just because it became
Right.
legal to grow your own. It
Right.
didn't change at all. Everybody's been driving high. I don't smoke weed, but
Right.
people have been driving stoned like
For a long
a
time.
long time.
Yeah.
But
See-
we're not actually seeing that. I have not seen, despite all the great work of the drug recognition experts, the state police who are specially trained to detect this, I have not seen a massive uptick in people coming in through the impaired driver rehab program with just drugged driving offenses. It's mostly alcohol still.
Mostly alcohol.
Oh, yeah.
Still.
Yep.
This was a pretty profound show, discouraging drinking and driving. I'm guessing there might be some folks that might even be watching now that might recognize you, because you said you teach the course.
Mhm.
What's it called again?
The impaired driver rehab program. That's a contract with the state of Vermont. They contract with various providers, and I'm just one. I happen to get the contract for 3 counties, even though I'm based in Lamoille County. I'm based in Stowe. I do travel up to St. Albans once a month and down to Middlebury once a month to either teach or help start with the teaching of the class.
So first time offense. How long is this course? The same length? First time offense, second offense,
Yep.
third. Okay.
Third offense, I think you're considered a lifetime. You're a lifer, which means your license is suspended for a minimum of 3 years. And at that point, you don't have to do the impaired driver rehab program class. You have to do an assessment. You have to be in counseling. You have to pay some fees. And you get the interlock device, which is that
Oh,
thing in your
yes.
car.
Yeah.
And that's a different deal. But with DUI 1 and DUI 2, it's a 10-hour class.
It's a 10-hour class.
Yeah.
So what's it like? Is it in an hour each, 2 hours each?
I do it in 2 days, 5 hours on a Saturday, 5 hours on a Sunday. Yeah, and people come in, and I personally think the material is awesome. It's fascinating. It's not about finger wagging like don't drink and drive, shame on you, this is terrible, don't you realize you can kill people? And it's really more about exploring someone's values. What do you value in your life? What's important to you?
I wondered about that.
And what are the influences? I think it's fascinating because it's not only like what are your values, but what makes human beings tick? How do we go about our lives making decisions? How do we make choices? How are we influenced to make choices? We're influenced in all kinds of ways that people don't even realize. We're influenced by our preferences, by our personality style. We're influenced by social media. We're influenced by our feelings,
Our relationships.
Our relationships. We're influenced by so many things, and we don't even realize how many things are actually making decisions for us.
Yeah.
And so this class is all about raising self-awareness. Let's think about how we think about ourselves and the world and how we feel and how that plays into our choice to drink, to not drink, to protect our values, to prevent bad stuff from happening down the road. That's what the whole course is about. And people, I think, really like it.
On an average course, how many people do you have sitting in front of you?
Average about 10 to 14.
10 to 14. How quickly, in your mind, do you look out at the folks that are there and say to yourself, the voices in your own head, oh, this dude is just not getting it. He's just not getting it. This one over here, we're having a huge impact on. I just know I'm never going to see her again or him again. But this guy over here is just rolling his eyes. He's just putting in his time, and this isn't having any effect. Do you do that in your head?
No. What I say in my head, and I believe truly, is that I don't really think that the course is going to make such a huge impact on whether or not someone chooses to drink and drive again. What I do think is, I do think that as a human being, if you have an interest in yourself, in the world, in some interesting research concepts, if you're just interested in having a good discussion using research, stories, concepts, then everybody who takes the course can get something out of it for their lives. Even if they're just like, I got to be here, this is stupid, I can't believe I got $400 and I got to sit for 10 hours and this sucks, I don't want to deal with this. Like, sure, there's a lot of people like that, but every single one of those people, in my mind, when I'm teaching the class or I'm looking at them, I'm hoping and I'm thinking, you know what, every single person in here can get something out of this class.
What about a mom or a dad who is watching right now that says, I'd love my kid to take this 10-hour course at 16 years old, 17, 18, 15, 14. Can someone come to your course and take your course even though they haven't been busted for DUI? And if so, what's the cost?
So sometimes the court diversion for kids, the Teen Alcohol Awareness Safety Program or the diversion program, court diversion, sometimes they'll send younger people who haven't gotten a DUI but have gotten into some other trouble around alcohol or drugs, they'll send them to the course. It's $220 for the course. But we don't actually teach it separately. And I've had numerous people come up to me after the class or during the class and say, Rick, this should definitely be taught in the high schools. And there's actually an 8-hour...
That was the next thing I was going to ask you is, why isn't this in the schools?
It's a great program. It's all about values, attitudes, influences, judgments, all kinds of stuff that we deal with on a daily basis, especially in this social media world. Like, raising our self-awareness is so critical nowadays. It's vital to sort of helping us navigate this digital world we live in, and I think it would be wonderful for high schoolers to have this curriculum. It's really good stuff.
We're talking with Dr. Rick Barnett. He is a licensed alcohol and drug counselor. His practice is in Stowe, and you've got a doctorate as a licensed psychologist. So you're a psychologist and a psychiatrist. Am I right?
No. It's interesting you should say that. People sometimes don't know the difference between one mental health provider from the next. I have a doctorate in psychology. It's a PSYD, so Doctor of Psychology. Doctor of Psychology. And interesting you should say psychiatrist, because psychiatrists are physicians who have gone to medical school after they've gotten their bachelor's degree. So they go on to medical school. They go through a traditional medical school training program, and then they decide after 4 years of medical school that they want to specialize in psychiatry. So there's a difference in terms of how the education and training is delivered for psychiatrists and psychologists. As a psychologist, you get your bachelor's degree, often in psychology, and then you go on for 5 or 6 years to complete a doctorate in psychology, which is not it's a graduate school. It's not medical school. It's graduate school.
What about when somebody's got a drug problem, alcohol problem, whatever it may be? They go to their doctor. Maybe they've got some depression, some anxiety, some underlying issues. You go into a doctor's office these days. I'm not talking about your primary, and it just seems like everything is so rushed. It seems like the doctors don't necessarily, not all of them, necessarily take the time to really sit down and look at their patient and take a good quality amount of time to say, what's going on? And for so many of us, if we sense that another doctor is rushed, we're not going to say, yeah, I'm here for a physical exam, but I also, I got to be honest with you, I've been really down in the dumps lately, and I'm having some anxiety attacks, or at work, I'm not really sure what they are. I get emotional very, very easily, very quickly, and they're leaving that doctor's office essentially undiagnosed. You seem like you're the kind of doctor who has a pretty good catch net, in the sense that you're finding out some real underlying issues that people might have, where you need to, I'm guessing, call your client's doctor and say, hey, here's what's going on. You probably wouldn't have been able to find that out in a 10 or 15 minute appointment, but this is what's going on, and I recommend such and such drug. Do you find yourself doing that often?
Well, you're pointing at a couple of different things. Oftentimes, primary care settings, clinics, medical practices, they are the de facto mental health or addiction treatment system. That's where they're the main gateway to get care. And the people that work in those settings are rushed to see lots of people, because that's where people go to get their care.
That's stop one.
That's stop one, primary care. If they don't go to the emergency room in some crisis and get access to emergency medical care or psychiatric care through crisis services or emergency care, then they're going to their primary care physician or nurse practitioner or physician assistants, and they do have a long list of patients waiting to be seen, and they have, the average, I think the average nationally is 7 minutes per patient.
Yeah. Wow, man.
It's 7 minutes. Now, there's a lot of great physicians and nurse practitioners and physician assistants out there, but they all work in the same system.
Yeah.
And they're under a lot of pressure to see a lot of people and
they're always behind schedule.
And try to help, and really try to help them. If someone comes in and says, Doc, I know, you only see me usually about once a year, and I've known you for about 3-4 years now. And so I kind of trust you. You kind of know me, even though I'm only here for about 10 minutes, for a visit, or if I have the flu or something, I might come in. But I'm really depressed. What should I do? And
hopefully someone has the guts to speak up and speak like that to their doctor. First off,
right, which they may not, and for a variety of reasons, especially in small town Vermont.
That's right.
Where
everybody knows everybody.
Everybody knows everybody, and do you really want to go in as a teacher, as a lawyer, as a local professional or public figure, or the person at the store or whatever, and say I'm suicidal, or I've got a sex addiction, or
I have a food addiction.
I have a food addiction, or I'm drinking too much, and then it's next thing you know, it's it feels uncomfortable for some people. And so I have the luxury in my office to sit with people for 45 minutes, an hour, every session, once a week.
Hammer through
like
it.
you said, and really get into what's going on with this person. Do we always communicate with each other as health professionals? I can say last week a primary care physician called me on a mutual patient, and was asking about their history, was asking about their addiction history, their mental health issues. Now, this physician happened to know the patient over a long period of time. And I had known the patient only sporadically over several years. So I hadn't actually worked with him recently. But he was asking some questions about medications and what could help this guy. Thankfully, in addition to the experience that you listed there that I have, I went on after I got my doctorate to get a master's degree in psychopharmacology. So I went further because I felt as though everybody and their cousin was being prescribed medications for one reason or another. If you look at the actual amount of medication that the average American is taking, I think 1 in 5 people takes a psychiatric medication or has at some point in their lives. If you look at or just any type of medication, a diabetes medication, a heart medication, whatever it might be, we're a pill popping society.
Yeah.
And so I wanted to learn about pharmacology, clinical psychopharmacology from the perspective of a mental health provider, like a psychiatrist, except I'm a psychologist, so I focus on the non-pharmacological, but I wanted to know more about biology, about medication, how it affects different body systems, how it affects people's minds. And I have the luxury now, like I said, of sitting with people for 45 minutes to an hour every week, and I can determine, does this person need a change in their medication? Do they need to try a medication? Do they need to come off a medication? I can actually sit there and assess that much better, I think, than a primary care physician.
Exactly.
Not because I'm better than the primary care physician, only because I have the required training to have me be expert and knowledgeable on the physical, but not as expert and knowledgeable on the physical as a person who's gone through medical school, but enough to know, because I have experience with the person in my office and I can read labs and I can understand what's going on with them at a basic level to make those recommendations.
Do folks need a referral to come and visit you, or can they just call your office and make an appointment?
Yeah, people can call my office it's at 802 area code 373-2909. Text is great, 373-2909.
In Stowe.
In Stowe.
But do you need a referral?
No, you do not need a referral.
Wow.
Anybody can call. My practice is pretty full, so I don't really have that much room. And I just want to be clear to anyone listening, I cannot prescribe medications, psychiatric or otherwise. In the state of Vermont, I'm not allowed to. If I lived in Louisiana or New Mexico, in Illinois, Idaho, or Iowa, I could prescribe psychiatric medications because
what's that all about?
Because of my training.
I know there's the legislatures in session now, and they're chatting about this, and all these new bills are popping up. So, why?
Yeah, well, this is one of the bills that hopefully would pop up and someone would take down off the wall. They oftentimes bills languish on the committee room wall. And I've been working on a bill for the last 4 years, and it's just hung desperately on the wall, not being taken up by the committees in which they sit, unfortunately. And like I said,
that is very unfortunate.
There's 5 states that have this law passed, and the U.S. military. So we have psychologists like myself who've got the required education and training who prescribe to our active military officers. We can prescribe to people in those 5 states. In the U.S. Indian Health Service, on reservations, we can prescribe medications, but for some reason not here in Vermont. No one has the political will to pull that bill off the wall and get some robust discussion. It's opposed by some very powerful people that have what they think is legitimate reasons to not have this bill be taken up for testimony.
What's the bill called, and what do you think what's the basis of their reasoning?
So the bill is, one of them is S81. It's in the final year. We're going to have to come up with another one next year if it doesn't get taken up this year. But S81, that's in Senate Health and Welfare, and H139, which sits in House Healthcare Committee. And there's a lot of reasons why there are some people who oppose it. Now think, we are in the middle of an opioid epidemic, right? And we are blaming the opioid epidemic on the excessive prescribing of prescription painkillers, prescription opioids.
Yes, sir.
So when you come to the table in that climate and you say, we need more prescribers, a lot of people are like, hell no, we do not need more prescribers.
Right.
Yet we have a situation, and we all know about it, that the state hospital shut down in 2012 due to Hurricane Irene, tropical storm Irene.
Yeah.
And they built a new psychiatric facility right here
Yeah.
up the hill. And we have emergency departments overflowing with people with psychiatric needs.
Very much.
We have difficulty finding psychiatrists in this state. If you live in the Northeast Kingdom, trying to find a psychiatrist is like trying to find a unicorn. You can't find them. And most of the prescribing is done out of these primary care settings. And that's perfectly fine that they're being prescribed there. I have nothing against that. The problem is that this is not the best scenario. If we can add a provider group that has the mental health expertise and the basic clinical medicine knowledge to be able to prescribe or de-prescribe medications, get people off medications when necessary, you're just adding one more tool in the toolkit. It's not meant to be a panacea. And what about buprenorphine? We just started the show with the Suboxone. You know how helpful prescribing psychologists could be to be able to prescribe Suboxone to these young people when they're being, coming back from an overdose, nearly dying. And you've got a bunch of physicians who have got authority to prescribe this medication, and they don't. They choose not to, or they only prescribe to a very few people.
Same story with methadone?
Methadone has other regulations associated with it, but yeah, a lot of people are terrified to prescribe methadone because it's more complicated, not only pharmacologically, but also the restrictions from a policy standpoint. The procedures involved fall under different federal regulations, so it makes it a little bit more complicated.
Naltrexone?
Naltrexone, yep, that's an antagonist medication. That's an easier drug to prescribe pharmacologically, but it's still another one of those medications that now a prescribing psychologist has the basic medical knowledge and prescribing knowledge, the pharmacological knowledge, to be able to help this workforce, to help Vermonters. And like I said, it's opposed. One of the reasons why it's opposed is because a lot of people say, we don't need more prescribers. The only help we need is, well, we have psychiatrists now from all over the country who are getting licensed in Vermont to do telehealth with patients in Vermont. So a physician sitting in New York City or in Alabama or in Florida, down in the sun, is Skyping in or using video conferencing into a mental health center or whatever, and helping to prescribe medications to people who may need medication. And that is definitely another tool in the toolkit. For some people, that could be extremely helpful.
Yeah.
But the problem is we have a national shortage of psychiatrists. It's not just Vermont. There's a national shortage of psychiatrists. So there aren't just a bunch of psychiatrists sitting around all over the state, all over the country saying, gosh, how can I get more patients? Everybody's overbooked. And a lot of them don't even take insurance. So what good is that?
What are these states that are doing this? You listed them off here. I want to just scribble them down.
New Mexico.
Yeah.
And Louisiana. Those two have been doing it the longest, very successfully.
Okay.
And one of the other three are Illinois, Iowa, and Idaho.
Okay.
But one of the arguments that psychiatrists and some medical organizations will say that it doesn't improve access. You've got the same mental health workforce shortage with psychology as you do with psychiatry. You see the same distribution of psychologists hanging out in urban areas, and there aren't psychologists out in rural areas ready to serve the people. And it's simply not true. It's true that we don't have good data to show that psychologists who prescribe or de-prescribe can actually improve access. It hasn't necessarily been published, or someone hasn't done the research yet to show that it has improved access. But the fact is that if you add people to the workforce who have the capability and the expertise to prescribe or de-prescribe medications, you're going to be helping people, period. Whether that makes a huge dent in access or not, right? And I would rather think about it. If you were to go to see somebody and you felt like a medication might be helpful for you, who would you want to get that medication from? Would you want to get it from a psychiatrist who's in Florida who you've never met before? Would you rather get it from your primary care physician who knows you sort of quickly over a few visits for medical purposes? Would you rather get it from a physician assistant who's helping the doctor's office, helping, manage different things, clinical situations in a primary care practice? A nurse practitioner who also certainly has the training and skills to prescribe psychiatric medications, but again, maybe under the same pressures as your primary care physician.
Sure.
Or a prescribing psychologist who you meet for the first time, you spend an hour with. They get a sense of what's going on. They don't whip out their prescription pad right away.
Absolutely.
They sit with you. They set up, if you're comfortable, that you set up another appointment later that week or maybe the next week. And if medications can be useful, would you accept a medication and maybe find that it could be helpful coming from somebody that seems to know you in that setting? I mean, it's a personal choice. A lot of people just want a pill. Go to their doctor. Doc, I got anxiety. I don't know what to do with it. I don't want to talk to anybody. Counseling is crap. Just give me something to take care of my anxiety. Sure, that's fine. If the physician wants to prescribe in that situation, that's great. A lot of physicians refer to counselors, say, you need to go talk to somebody. I don't want to just prescribe you a medication. Go talk to somebody. And Vermonters, I can tell you a funny story about when I moved back to Vermont. I'm a native Vermonter. I grew up in Stowe. And I moved away. I came back. And a guy, my new neighbor, comes across the street in his walker. And he's like, how you doing? Are you some sort of head shrinker? That's what he said. He comes across the street in his walker. You some kind of head shrinker? I was like, yep, I'm a psychologist. He's like, well, good for you. All right, nice to meet you. And he just went across the street. A lot of Vermonters are not quick to reach out for help for mental health issues. So
for a whole lot of different reasons.
Yeah.
Your website, you talk about this way to communicate with you. I can't remember what you call it, but through Skype you can do some online conferences with you.
Telehealth. Yep. Telemental health, telemedicine, telepsychiatry, telehealth. That's the broad term. Yep.
But what's nice is that, I would rather get a prescription from, if you and I were chatting via telehealth and for whatever reason you weren't able to get a good read on me, you could say, hey, look, how about next Wednesday, meet me in my office and we'll talk about this some more. Mm-hmm. So that you can witness my nervous foot, jittery foot tapping the floor and things like that.
Mm-hmm.
That's very cool.
Mm-hmm.
that you have the ability to do that. How is that? Is that something that's doing well?
Yeah. So the governor signed a bill into law in 2017 that allowed psychologists, mental health providers to deliver telehealth services to clients, patients, online, real time, and have insurance companies pay for it. Mm-hmm. And they removed a restriction where the patient had to be at a medical or healthcare facility. Mm-hmm. Now clients can be in their homes. They could be at Starbucks, at McDonald's. They can be anywhere they want to be if they want to have a counseling session. That went into effect October 1st, 2017. And I worked really hard on trying to get that bill passed as part of my work in the legislature. I'm the legislative chair for the Vermont Psychological Association, also a paid lobbyist, believe it or not. Don't get paid very much. And I'm up against some other very powerful lobbyists for this bill that I'm trying to get passed, which is very discouraging, but I'm going to keep up the fight. And the telehealth bill was significant progress. There's been lots of progress over the years, and there's going to be more progress down the road in terms of telehealth. But a lot of people aren't picking up on it. I don't know if people know, in case you're watching, that Medicaid, Blue Cross Blue Shield, and all insurance companies are required to pay for your telemental health sessions. If you want to see a counselor online, you can do that. And if you have insurance, your insurance will pay for it.
No matter where that health professional is.
The health
residing.
professional, it has to be in their own office, their designated health office. They can't, like I can't be in a Starbucks.
Sure. But they can be in Florida.
If they're licensed in Vermont, they can be in Florida. If I was to do telehealth with someone in California, if I'm not licensed in California, I'd have to either apply for a temporary license or whatever to be able to. I don't use Skype because that's not secure, but I use my platform. I can't do that in California. Any state that I'm licensed in New York and Vermont. So I do have some New York clients I do that online with, and some Vermont patients I do online.
So your site is bpshealth.com.
Yep.
What's the BPS?
Biopsychosocial health.
Biopsychosocial health.com.
Yep.
So you're dealing with people who are, we've talked about opioids. We've talked a little bit about alcohol. What other kind of interesting addictions do you see? Dare I even ask? I'm guessing gambling is.
That's actually how Carter got started. I had a grant. I founded Carter because I was approached to apply for a grant with the Vermont Lottery.
Carter.org.
CarterVermont.org. Yep.
Yeah.
Carter Vermont, all lowercase, all one word. CarterVermont.org. In 2015, we founded Carter, me and a couple of colleagues, and we applied for the grant from the Vermont Lottery to provide a resource for people looking for help for gambling problems in the state of Vermont. That is, we provided a hotline so people could call 24/7 for help. We did trainings all around the state to train counselors and other people to raise awareness around gambling addiction. And we referred people to counselors. So if they called for help, we could refer them to a network of counselors. So we did that for 4 years. When the Vermont Liquor Board and the Lottery Commission merged, I don't know why still to this day, but they decided that they didn't think that Carter was doing a good job with the funds, and they terminated our contract. They didn't allow us to reapply for the contract. The Liquor Board took over, and I have no idea what happened to that money and who's running what used to be called Problem Gambling Vermont. So that's what I found. That gambling addiction, let me tell you something. I have a couple of gambling addicts right now. Again, that is a very, very devastating addiction. The suicide rate from gambling addiction is 5 times higher than any other addiction.
Complete loss of hope.
Yeah. I mean, it's one thing to be like strung out on opioids or alcohol and just be, like running the streets or, trying to survive and whatever. But if you stop using, if you get help and you stop using, your life can get better pretty quickly. You can put things together. But if you're gambling for 3, 5, 10 years and you've just drained your retirement account, your wife's retirement account, your kid's college fund, you've embezzled from your companies, and you're homeless and you're penniless and you owe $1 million, like, you don't just stop gambling and things turn around fast. You're facing many years of trying to put the pieces back together, and I think that's part of the reason why the suicide rate is so high for gambling addicts.
So they're addicted to the chance that they might be able to gain some ground on their financial upside downness.
It's the most fascinating addiction because it's predicated on it. You're addicted to hope.
Addicted to hope.
You're addicted to hope. You're addicted to, like, this next thing that I'm going to do is going to make everything better. If you're addicted to alcohol or heroin, you think it's going to make everything better for a second. You're going to get high, you're going to get drunk, whatever. It's going to be good for a second, but it's a total shit show.
Yeah.
It's a shit show. But if you're a gambling addict and you think you actually win, it's going to make all my problems go away. I'm going to keep investing in this ridiculous self-destructive behavior because, it's going to make my problems go away.
But once you've lost hope in hope,
it's that's why it's so hopeless, and that's why hopelessness is one of the key indicators for suicide risk.
What do you tell somebody that's in front of you that's addicted to gambling? I mean, where do you begin with something like that?
That's a great question. And again, it's also very different from other addictions. Where you begin with gambling addiction right off the bat is very concrete. You're not dealing with the emotions. You're not dealing with the behaviors per se. You're talking about finances right off the bat. Where do you get your money? How much are you spending?
Right.
Let's track this shit.
Yeah,
Let's pay attention to what's going on here mechanically with what you're doing with money and gambling. So how often, where are you gambling? What's your favorite thing to do? What type of gambling? How much money do you spend on? Where do you get your money? Let's track that. Let's find out what's going on here. Let's put limits. Let's block your access to any type of credit cards or loan opportunities or whatever.
Sure.
Let's do whatever we can, just on a very practical level. That's where you start with people with gambling addiction.
You've known clients who have actually taken out loans to
Oh yeah.
gamble those loans?
Yeah.
Ouch.
Yeah. And lost it like in a matter of minutes.
And
Take out a $2,000 loan and put it online into some gambling app on your phone. Literally in a minute, $2,000 loan gone.
and to be able to secretly tap into your wife's account or what have you, your kids' trust or whatever it may be. I can't even imagine that.
Yeah.
How sad.
I know. That's terrible. It is terrible. I've seen some very painful situations. So that's why I was sort of bummed that I thought we were doing good work for the state to help raise awareness around gambling addiction, but they felt otherwise. So hopefully that money's being put to good use. If I have an opportunity to reapply for that grant, it's $100,000 a year to provide those services, which isn't much, but it's a lot of money to help with, phone calls and directing people to get some help in doing these trainings to raise awareness for people.
Will you please stay in touch with me with regard to that specifically? And if you make any headway with that, please come in here and let me know about it. Let everyone know about it, because I'm just going to say this. First off, I want to have you back in here. We could talk about this all night.
Mm-hmm.
But if things do go well with the alcohol, what is it, the alcohol board and
the liquor board and the lottery,
and the
liquor and lottery, they're merged now, and I think that's
All right.
part of the problem. I think the lottery was doing a good job with what they were doing. The liquor was doing a good job with what they were doing. Then they merged, and I think the liquor board took over. They didn't understand what the lottery was doing, and I don't think they really understand problem gambling. And
if you guys sign a contract, call me so I can get you back in here right away.
Okay. You could contact the liquor board if you want and be like, hey, I heard about this gambling thing. I think what's happening with that? You should give it back to Carter.
Done deal.
That'd be awesome.
Well, done. Absolutely. And what do we need to do to get Vermont to sign this legislation?
Yeah, I mean,
What do we need to do?
For prescribing psychologists, again, it's about having a really good discussion around the need for high-quality mental health services. It's fine to get psychiatric medications from your primary care doc. It's fine to try to get an appointment with a psychiatrist and get medications. It's fine to try to get on telehealth and use that as a way to get medications. But it's not just about getting medication. It's about the whole package. It's about knowing when to come on and off medications, having really thorough discussions with patients about what their feelings are about medications. So if anybody wants to contact their local legislator,
Yes.
please do. S81 and H139. And there's a lot of reluctance right now for politicians to take up this bill for fear that they're going to piss off the wrong people.
Right.
Because, again, a lot of high-powered people are opposed to this, unfortunately. And I've gone through everybody and their cousin to try to garner support. And we have a lot of support from a lot of different people. But the people who count, unfortunately, in the political arena, really wield the most power, and they're not that interested in supporting this bill. Which
You
is
want to drop
unfortunate.
any names, or you just...
I've actually written pretty publicly in the Bridge here last year, the year before, and and written on the Vermont Digger. The Vermont Medical Society is unfortunately super opposed to it. UVM psychiatry is super opposed to it. Almost all psychiatrists, not all of them, but probably most of the psychiatrists in the state of Vermont and the country are opposed to anybody prescribing. And frankly, it's just a turf war. Anytime there's a scope of practice issue, nurse practitioners, naturopaths, dentists, optometrists, you name it. There's always, whenever there's an expansion of scope of practice, there's going to be a group of people that try to push back and say, we can't have this. This is dangerous to the public. It's going to kill people.
Yeah.
They shouldn't be handling these medications. They don't have the required medical training to be able to do this. They should go to medical school. It's going to be a safety disaster. The public is going to be harmed. This has been vetted by the Office of Professional Regulation, who knows what is required for nurse practitioners and other health professionals to do what they do. They have looked at this bill, they have looked at the history, and they are 100% comfortable coming out and testifying in support of this bill. And the buck stops with them. They protect the public.
I got to get you back on, man. Promise me you're going to come back on soon.
I will.
All right.
Love to.
To learn more, this is, again, Dr. Rick Barnett. His practice is in Stowe. bpshealth.com, cartervermont.org, addictionvt.com. I want to thank my presenting sponsors so much. Gauthier's Quality Grounds and Maintenance of Orange. You saw him in here just a little while ago. Jason Gauthier, very busy guy, residential and commercial. He'll take very good care of you. Find him on Facebook, Jason Gauthier from Gauthier's Quality Grounds and Maintenance. Wright Electric, Chris Wright. What would we do without this guy? I say it every time. I mean, he's in here tweaking the audio and helping us out so much, and we appreciate him. Again, one of my presenting sponsors. We love the pieces out of Chris Wright and Wright Electric. Thank you so much. Project Independence, active adult day health services right here in the heart of Barrie on North Main Street. They are operated in partnership with Gifford Retirement Communities, pibarrie.org, to learn more about what you might be missing. Fontaine Forestry and Millworks of East Montpelier. This beautiful table that you see, custom cut by Mark Fontaine and his family. Fly on the Wall Productions, and of course, CVTV, Central Vermont Television, where we are each and every time we do this podcast, channel 192 and 194. Get yourself dialed into your community, cvtv723.org. Thanks to Dr. Rick Barnett for all of your time. God bless you for schlepping all the way to the Granite City from Stowe to come on the show. I really appreciate it. I hope you come back in real soon.
Definitely.
Good luck with everything. Again, get in touch with him if you need help in any of these departments that we're talking about, from depression to anxiety, any kind of counseling, drug use, alcohol use, whatever it may be. And if you get pulled over and you get a DUI,
Right here.
This is your man right here that you're probably going to see. And as you can tell, he's a pretty down-to-earth guy. I think you'll enjoy your experience with him. That's going to do it for now. Thank you ever so much for tuning in tonight, for subscribing, for sharing, for commenting. We appreciate it so much. We'll catch you next time.